I want to take the next several minutes to talk to you about your clinical experiences during your intern year at Riverside. Riverside serves as an independent academic medical center. What that means is we don't have a medical school attached to the walls of our hospital, but we do have several official affiliations, including University of Toledo, Ohio University, OSU, and NeoMed. In addition, we have a number of medical students rotating from a number of medical schools across the country. The bottom line for you is that when you are on your inpatient rotations at Riverside, you will have medical students with you. And that way you can start to make that transition that I think is extremely important from somebody that's been a pure learner to somebody who's both a learner and educator. In my opinion, one of our greatest strengths is our teaching faculty. We have a very large volunteer faculty who come from a number of different clinical programs across the country. The things that attract them to Riverside are certainly not the oceans and mountains that are in Columbus, Ohio, but medical education is important to all of us. The reason that people come here is because they want to be involved in teaching. They don't necessarily want to have to fight for their next NIH grant, but medical education is so part and parcel, it is so important and integral to what we do at Riverside. People that don't want to teach, they don't come here or they don't stay here. A little background about me. I grew up in Northeastern Ohio. In fact, I did everything from kindergarten all the way through the end of medical school within about a 20-mile radius of one another. At that point in my life, I thought I never wanted to be in Ohio again, so I moved to Charleston, South Carolina, and did my residency and fellowship at MUSC. A number of factors brought me back to Columbus, Ohio, and to Riverside, including some of the factors I just told you about for other faculty. I joined practice in 2006. I became the medical director for our simulation center from 2011 to 2017. I've served as a GMAC chair for two different terms from 2014 to 2018, and I've taken over the transitional year program director in 2015. So although this is my 6th year of recruitment as a program director, I've been involved with medical education at Riverside for a while. I definitely want to take a couple of minutes on this slide because I think it highlights some of the things that make Riverside truly unique as an experience for our prelim and transitional residents. Um, this slide represents the totality of our GME program. And so, first of all, some of the things that are notably absent, what you don't see on here are a number of medicine subspecialty fellows, other residencies such as anesthesia or radiology. And what that means for you is that you're not going to have other learners that are diluting your experience, that are taking away your procedures, that are potentially impacting your autonomy as you learn how to manage patients. As I run through the numbers, we have a total of 18 internal medicine residents per year. We just increased that from 15. We have 6 family medicine residents per year. We have 5 OBGYNs. We have 5 general surgery. We have 4 prelim surgery residents. There are 2 dermatology residents per year, which I'll talk about in a second. And then we have a total of 3 psychiatry residents per year, in addition to some medicine subspecialties, including sports medicine and hospice and palliative. If we go back up at a prelim and transitional year, we have a total of 18. That 4 with the parentheses of 6 next to it that you see, 2 spots are allocated as part of a categorical program for our dermatology residents. The other 4 spots are only a prelim year. Although they are listed under different ACGME numbers, they function as one large program, and I'll talk about that in a little bit more detail in a little bit. So you can look at our prelim and transition year as one large 18-person program. Well, why is that number important? Well, there's going to be a number of places that you interview that are in academic centers where you will have a very large categorical medicine residency and a very small prelim and transitional program. It is easy to be the forgotten few when that happens. In our program, our prelim and transitional residents represent a significant portion of the intern workforce, which means that you can't hide. And quite frankly, the obligations and the expectations, the opportunities are going to be exactly the same for you as they are for our IM categorical residents. In fact, before I was in my current role, it would be 6 months before I knew who was internal medicine, who was PM, who was TY, because for the things I do for pulmonary, for critical care, the expectations, the opportunities, the procedural opportunities, those are exactly the same between our IMPM residents as it is for categorical residents. I think that's really important because if you are pushed to the side, if you're some of the forgotten few, if you are the vast minority and they focus on only their categorical residents, it will adversely affect your experience during your intern year. As I mentioned before, our prelim and transitional program function as one large program. We do have two different buckets because of ACG meet caps. Uh, our preliminary medicine falls under internal medicine for an ACG meet cap, and our transitional year is its own ACG meet number. That being said, the programs are essentially identical. The number of core rotations, the number of electives that you do are exactly the same. If you are interested in Riverside, it behooves you to rank both programs, and we will rank you for both. The things that we're looking for are fairly simple. We expect that you're going to have good medical knowledge. We get people that have really good scores and have done really well in school, but that by itself is not enough to make a good intern. We want people that are going to have a positive attitude and a strong work ethic. Next year is going to be no different than anything else you've done. You're going to get out of it what you've put into it. Although you've worked really hard during medical school, the formative time of the physician that you're going to become is going to start during your intern year, and it's going to carry through your categorical program. It's really important to make the most out of that. Our goals for you are also fairly simple. We want you to have a solid base in medicine. Even though you're going into something that's going to be different in your advanced program, if you were to have a person collapse on a plane, or if you were to have a family member ask you a medical question, we want you to feel comfortable fielding those questions or those situations. But we also want you to be able to expand your area-specific interests. You're going to have a unique opportunity next year to do rotations and electives that may have an impact on your future specialty, but you won't be able to do in your advanced program. For example, if you're going into dermatology, doing things like rheumatology or infectious disease, or if you're going into radiology, things that have radiographic or clinical correlates such as neurology or pulmonary, or if you're going into anesthesia and you want to have extra ICU experiences or cardiac imaging, this is your time to make the most out of those experiences so that you can be the best advanced resident possible. We do allow flexibility in the curriculum so you can have a balance between rotations that have more rigor and difficulty with some lighter rotations. More than anything, we want you to be prepared for your PGY2 year. Although the workflow and vernacular is going to change in your advanced program, there are concepts that are ubiquitous to the medicine. Being able to effectively and efficiently gather subjective and objective information from patients, being able to put that in a meaningful format in your brain to do presentations, and not only that, but actually being able to take that information and start to formulate assessments and actually intervene on that information and formulate plans. That is a concept that is going to be important no matter what you go into, whether you're an intern in your cardiology rotation or whether you're a consulting physician talking to a referring doctor. Those concepts are really important to grasp during your intern year, and we offer the breadth of clinical experiences to do so. One of the improvements that we have made in our curriculum design is to transition to a 4+2 model, where you will do 4 weeks of one of our core rotations followed by 2 weeks of an elective or lighter rotation. This was changed based on the feedback of previous graduates and is really designed to avoid burnout through the course of the year. Although somewhat difficult to read, this is an illustration of our templated schedule where you can see more challenging rotations intermixed with where you can see that there's a balance between elective time and our core rotations. Although the 4+2 model will change some of our 4-week rotations to be broken down into pairs of 2-week rotations, you will still receive a total of 8 weeks of general medicine, 4 weeks of ICU, 4 weeks of cardiology, 4 weeks of emergency and ambulatory medicine, 8 to 10 weeks of medical subspecialties. You will do 2 2-week blocks of night float, 2 weeks of night ICU coverage, leaving roughly 12 to 14 weeks for general electives. I know that general electives are extremely important to you, so you can get the experience you need, and they're important to us as well. This represents a number of electives that are hardwired within the walls of the hospital, but is not an all-inclusive list. We've had a number of residents that have designed other elective experiences, either within Riverside or at an outside institution, as you are allowed to do a 4-week outside elective with us. These can either be done as 2-week blocks or 4-week blocks. The bottom line is that if there's something that you have an interest in, we want to help facilitate that so you can get the best clinical experience possible. I know that research is important to a number of our applicants, and a number of you have active research projects that are ongoing. We do offer research as one of our elective blocks. This can either be done through the walls of Riverside or as an outside rotation. If you're trying to finish up a number of projects that you had the best intentions of completing during your 4th year, we do offer that as an opportunity to complete some of those. Several people actually have more of a physician scientist track in their future, and they already have approval from IRBs at their future institution and have a mentor, and so they will work through there. And we also have a number of ongoing projects that you can have substantive input with Riverside, as we do have a full-time research institute that works with our residents. Go through some of our samples of services. Each resident will do a 1-month ambulatory medicine rotation at the Riverside Community Medicine Center. This offers faculty preceptors, provides supervision, support, and teaching, has a fully graded Epic EMR, and has built-in administrative half-days through the course of the week. There is no call, no weekends, and generally it is Monday through Friday, 8 to 5. Emergency medicine has been honestly completely revamped over the last couple of years, and now is an outstanding rotation with a wide breadth of different clinical experiences with exposure to trauma, NIH, stroke assessment, sepsis, acute coronary syndrome. You'll do a total of 14 10-hour shifts during that time. There's also built-in didactic and simulation education as part of your experience. General internal medicine is done in a number of different potential clinical settings. Clinical medicine, which is the classic clin med that you probably did during medical school, consists of a resident-driven service with a fair amount of autonomy. That includes 2 PGY3 residents, 2 PGY2 residents, and 3 interns along with 4 medical students. And we also have a hospital med service that either occurs through COPC or Med1, which are our 2 hospitalist groups. That is much more of a nuts and bolts of hospital medicine that works on throughput and a number of common medical diseases. All of them are excellent rotations with different experiences, and you'll have an opportunity to see each of these. Typical day, you'll come in at 6:45 and sign in from night float till 7:15. Morning report happens from 7:15 to 8. Resident rounds occur from 8 to 10. Attending rounds happen from 10 to 12. And noon conference occurs from 12:15 to 1. The rest of the day is the dotting of I's, crossing of T's, where you're getting admissions, finishing rounds, etc., and you're signing out to night float from 4:45 to 5. For cardiology, we have now transitioned to 2 consultative services rather than a primary and consultative service. This is designed to provide an exposure to a wide variety of common and less common cardiac pathologies, and has been actively revamped over the course of the last year based on resident feedback. Critical care medicine is probably one of the tougher rotations you will do, and while I'm biased, I also think it's one of our best educational opportunities. We have a 31-bed ICU that consists of 2 teams, each with 15 to 16 patients. Each is led by an upper-level resident. We do have night float and days off incorporated within the schedule. There's in-house critical care attending support 24/7 so that nobody ever feels like they're left on an island. The days are a little bit longer with this, where you sign in from night float from 6 to 6:15. Resident rounds occur from 6:15 to 9. Attending rounds happen from 9 to 12. And the rest of the day is getting admissions, doing procedures, etc., and you're signing out to night float from 5 to 6. You are also excused from any morning reports or noon conferences during that month. The last part of our curriculum I want to discuss is our night float rotation. I'm sure that you're going to interview at places that don't have a night float requirement. And while that may seem enticing on the surface, I think it's a mistake, and I'll explain my reasoning for that. First of all, night float I think is really important no matter what kind of physician you're going to be. It offers an opportunity where you have to triage different levels of acuity for patients, where you have an opportunity to see more undifferentiated patients, and where you strip away some of those layers of safety so that you start to make your own decisions. The other reason, which is maybe a little less obvious, is that hospitals are 24/7 services. And so if a hospital doesn't need you during nighttime, they probably don't need you during the day. And if you're an ornament on the tree, if you're superfluous to the way that they deliver care, then you're going to feel that, and it's going to adversely affect your educational experience. The other benefit of our night float system is that it covers Sunday through Friday. And so that only leaves Saturdays, and you will have roughly 4 to 5 Saturdays through the course of the year. But otherwise, there are no nighttime requirements outside of those rotations. I appreciate you taking the time to listen to this brief overview of our curriculum. In general, I think that our curriculum rotations are designed to balance the exposure, experience, and well-being of our residents. That being said, we are constantly trying to improve and optimize the value of the educational product that we deliver, and therefore we take feedback from our residents, so some of the things that you see in these slides may change slightly based on the feedback we get through the course of the upcoming year. Thanks again for taking this time. We look forward to your interview.